Symptomatic multiple myeloma needs to be treated, unlike smoldering, which is more controversial. But this population, because they presumably have hypercalcemia, renal insufficiency, anemia, or lytic disease, we want treatment that's going to be rapidly effective at reducing those symptoms and also allow a deep remission and not interfere with stem cell collection. So with those objectives, studies have shown that doublet therapy clearly works, but triplet is better. And it's interesting, for the longest time, a lot of US physicians have been using the triplet therapy, lenalidomide, bortezomib, and dex, without any substantiating phase 3 studies. So that RVD was based primarily on phase 2 data, but until this past year when the SWOG 777 study was published. And this was basically newly diagnosed symptomatic patients randomized to either RVD triplet therapy or RD doublet therapy. And this showed a significant improvement in response rates, particularly deep responses, PFS, and OS. Yet there was toxicity noted with this triplet regimen. There was tripling of both neurologic side effects as well as GI side effects. However, it's important to remember that when this study was designed, bortezomib was being given IV or intravenous twice weekly. We know that that's not as well tolerated as sub-Q because we know that the toxicity of bortezomib is related to its Cmax, not at the area under the curve. So by giving it subcutaneously, we know that you can get comparable efficacy, but without that high Cmax, so less toxicity. But this is at least putting the toxicity aside, which we think is going to be mitigated by subcutaneous injections. We now have phase 3 randomized study level evidence that triplet therapy is better than doublet therapy for induction in newly diagnosed patients. Now, what else could we do besides that regimen? We could play around with the individual drugs potentially. In Europe, where there's a lot more cost constraints and drug access issues, perhaps the lenalidomide sometimes is replaced by thalidomide, but we do believe that lenalidomide is a more potent agent. There's also studies being done to replace the bortezomib with carfilzomib. So KRD is a very active regimen, and that was also studied by Italian group at ASCO called the Forte study, where KRD, carfilzomib, lenalidomide, and dex, was compared to carfilzomib, cytoxan, and dex. And that's yet another combination. Some folks do use a cyclophosphamide instead of the IMiD. And that study showed that KRD did result in deeper responses, both VGPR and better, as well as CR. However, it did also slightly increase toxicity, both rash, minor LFTs, and slightly decrease in stem cell collection. So I think the triplets do seem to be the way to control newly diagnosed myeloma, and definitely PI is a part of that. And IMiD seems to be preferable to alkylating agent. There was another study that compared VTD to VCD, and that was bortezomib thal-dex and bortezomib cytoxan-dex, and that showed slight superiority with VTD in terms of depth of response. So PI, IMiD, and steroids seems to be optimal, but there are, I would note, some patients where cyclophosphamide may still have a role, and that would probably be somebody with acute renal failure, perhaps an inpatient where it can be difficult to get the IMiD delivered promptly, somebody who's very bed-bound or has poor performance status where they have a higher thrombotic risk, making the anticoagulation also potentially challenging. But I think it's nice to have choices, but clearly the SWOG 77 study really informs our induction therapy as showing that RVD is a really great frontline regimen. So we now have the evidence for triplet RVD therapy, but the question is, what do we do next? Can we go beyond that? Now, the evolution study that was done by the Mayo Group showed that adding cyclophosphamide to do a 4-drug regimen didn't significantly increase responses, but did result in increased neutropenia. So it doesn't seem like quadruplet, at least that particular quadruplet, is better than the triplet. But the question is the new monoclonal antibodies that have been approved, elotuzumab, the anti-CS1 monoclonal antibody, as well as daratumumab, the anti-CD38 antibody, how might these factor in with the RVD backbone? And so at ASCO, we had 2 different studies that were presented. Elotuzumab was added to RVD, and it did seem to result in very high response rates, but there was a concern about a slight increase in infectious complications. And Dara was added to carfilzomib, lenalidomide, and dex, or Dara-KRD. And that regimen was also generally well tolerated, with the main toxicities being similar to KRD, and the depth of response was quite impressive. However, these are both relatively small studies of 20 to 30 patients or so, and primarily we only have response rates. We don't yet have those PFS type of endpoints. So these these quadruplet therapies with monoclonals up front will need to be studied further, and it may be particularly important in non-transplant eligible patients where there is not that ability of transplant to consolidate. And so we'll have to see how these regimens pan out in the future.